Hi everybody, I'm Sarah Green. I'm the Executive Officer of the Health Services Research Association of Australia and New Zealand. And I'd like to begin this morning by acknowledging the traditional owners of the lands on which we meet and to pay our respects to elders past and present. Really great to have so many of you join us this morning. I know it's a really odd time for us all. Just a little bit about the Health Services Research Association. We're a member-run organisation set up to promote networking, education and training for health services researchers in Australia and New Zealand. And these webinars are one of our key activities, and we try and run them at least once a month on health service and policy research and methodology. We're always keen to hear from participants about other topics and speakers that you'd like to hear present, and particularly at the moment, if there are any issues around COVID-19 and how that's impacting on the research community. If you've got any suggestions for topics, to let us know. You can just email me and I'll send out my email address after this event. Some ways we're quite lucky. Our other main activity is our biennial conference, Health Service and Policy Research Conference, and that's not due to be held until December 2021 in Sydney. So I do hope everything will be back to normality then. And a couple of our other key activities, our mentoring program and our awards program, should hopefully go ahead this year as normal. A couple of housekeeping matters this morning. So you should be able to see all of the slides this morning and the little talking head videos and hear everything, but we can't see or hear you. But you can communicate with us using the chat and the Q&A buttons at the bottom of your screen. If you move your mouse around, you should be able to see those. And the presentation this morning should go on for about 30 to 40 minutes. And if you have any questions, as I say, type those into the Q&A button, and our chair this morning will keep an eye on those, and she'll put those to Sue and Christy at the end of their presentation. I'm also recording the presentation, and we'll have that online in a day or so. I think I've covered everything. I'm going to hand over to Associate Professor Kim Dalziel, and Kim is a health economist at the University of Melbourne, and she was on the judging panel that awarded this research as the best quantitative research paper awarded by the Health Services Research Association this year. So I'll hand over to Kim.
Yeah, welcome everyone, and we're so pleased to have Sue and Christy with us to present their research. I guess when I was chairing the awards committee for the best overall paper, we were just so taken with this paper, and I think it had such high scores from all of the judges. And the thing that really struck us was that there was a really serious commitment to bringing an evidence base to this particular program in a really rigorous way. We really appreciated the rigor of the evaluation and the work that went into this paper, but also combined with quite a complex intervention. So it didn't strike us as an easy thing to evaluate. So a complex intervention combined with a really rigorous evaluation, and then I guess also just such a significant question for the Australian policy landscape and for improving health and birth outcomes in Australia. It wasn't a piece of work that we'd seen very much similar to before, and it struck us as being so significant for Australia and for Australian outcomes. So we really appreciated that you submitted it, and we were so pleased to have given the paper the best overall paper award. So thank you for that. Just a very quick introduction to Christy and Sue. So Christy is from the Institute for Urban and Indigenous Health, and she has had these very critical roles in being the birthing and early childhood services manager at that institute, and she's previously been the manager of the birthing in our community service. So just brings a wealth of expertise and knowledge from her role in those programs. And then Professor Sue is internationally recognised for her leading work in the field of midwifery. She has a stellar research, education and policy career and has made fabulous contributions in those areas. And I guess what we're really appreciating in Sue's career at the moment is these links with the First Nation researchers and the contribution she's making to the Australian and the international research community around improving midwifery outcomes for Aboriginal populations in Australia, and I guess that others are learning from the work of Sue all around the world. So it gives us great pleasure to have Sue and Christy online today to present this work for the Health Services Research Association. So hand over to Sue and Christy, and please add questions as we go in the chat box. I'll largely visit those at the end of the presentation. Thank you.
Thanks very much. That was a lovely introduction, thank you. And I'm going to hand over to Christy to get us started.
Good morning. First and foremost, we'd like to recognise the traditional owners and the Indigenous cultures of this land on which we meet on today. I'd also like to pay my respect to my elders, both past, present and emerging. So yes, thank you.
Okay, we're going to do a bit of a tag team today, and hopefully we're in different locations, of course, social distancing, and hopefully we'll be able to pull this off quite smoothly. So let's get started. And we just wanted to set the scene by showing the stats. We don't want to talk a lot about the statistics, but what we do want to say is that we think that the area of maternal, infant, child health is a really critical area that has long-term implications for families, and the trajectory that we're trying to change and turn around is in these two areas. And at the moment, we've got Aboriginal and Torres Strait Islander mothers dying in childbirth 4.6 times higher rate than non-Indigenous Australians, and for babies that's twice as high in the first year of life as well. And the large majority of babies the large majority of child mortality, children dying in Aboriginal and Torres Strait Islander, children dying under the age of 5, 82% of them are under the age of 1, and a large majority of them are due to preterm birth. So that's why we're really targeting pregnancy to try and make sure we can make a difference to both mothers and babies. And what we've done in this program that we're going to tell you about is we have managed to reduce the odds of preterm birth by about half for the mothers that came through our service. And in that period of time that we did this research, 22 preterm births have been avoided. And that, I don't know if that sounds like it's a lot to you or not very many, but it actually is an extraordinary amount. And there's not many programs across the world that I've know of at all that have seen this kind of a reduction in preterm birth. So we're really excited about this program. As Sarah, I think it was, who said, or Kim, I think in the introduction said, it does sound like a complex intervention that was actually quite difficult to do, and it was. So we're going to tell you about all the different parts of the intervention and how we think they're working to make a difference to preterm birth. And we're also going to show you the results of the study and a bit more of the data. So it was a 5-year study, and it was called the Indigenous Birthing in an Urban Setting study. It was NHMRC funded as a partnership study, and we had 3 partners in that in the partnership, which Christy's going to talk a bit more about in a minute. It was set in southeast Queensland and in actually South Brisbane. So that's the setting, and Christy's going to give you an overview now about the actual program.
Okay, thanks, Sue. So what is birthing in our community? well, I suppose to ensure our families feel safe, connected and culturally supported, a hub at Salisbury was established to provide a safe haven for our mums and bubs and families to receive their care. There they would attend community days, connect and would take the opportunity to learn from each other. So all mums that were carrying an Indigenous baby that births at the Mater Mothers Hospital here in Brisbane would come onto our program and would have a dedicated midwife who would be there the day that baby was born, and also a Deadly Black family support worker to help her navigate through the system. In addition, the program provides a multi-layer of service and support, and it was all depending on mum's needs. And so this could have been something as simple as transport, parenting support, connection, learning about budgeting, cooking, perhaps even understanding about contraception or immunisations. But ultimately the program was there to help build our families' trust and knowledge of the healthcare system so they can continue with their healthcare journey our baby was born. I'll skip to the next slide, Sue. So this is ultimately how we came about the multi-agency partnership. And again, this partnership, we couldn't have worked if we weren't working as a collective. So in 2004, we had a Murray clinic that was established with the Mater Hospital, whereby all of our families that were birthing with the Mater would actually consult through the Murray clinic, but we didn't have a dedicated midwife, I suppose. And there was an evaluation that was done of the Murray Clinic in 2011, where we had obviously a lot of people actually support this evaluation and came to the conclusion that the Murray Clinic was delivering a service which was great and well respected across the community here in Southeast Queensland. However, there was more we could do. And come 2012, that's when the World Cafe took part, where the businesses engaged multiple stakeholders across Southeast Queensland, whether it was from clinicians out to our services themselves and with community, mums, bubs, and as well as our elders. And we came together to talk about, you know, blue sky dreaming. What is our ultimate view as to how we can care and provide for our families? So that was when an MOU was actually established across AICS Brisbane, the Institute for Urban Indigenous Health and the Mater, whereby each of those services who were currently delivering different services came together as a collective and provided a new service called Birthing in Our Community. So that was established in 2014, whereby the IBIS study was then implemented in 2015. And I mentioned before about the hub that was then created out at Salisbury, which is our safe haven for our families. So that was, we moved in there in September of 2016, and over the last 4 years, we've just been refining our goals and our service and seeking feedback and expanding on what that does look like. But importantly, really relying on the partnership from AICS, IUE and Mater and the leadership that comes with that and having the buy-in from the top level down. I'll go to the next slide, please. So our Deadly Family Support Workers, they're a team of strong Black Deadly women here in Southeast Queensland that I'm incredibly proud of. The feedback that we've received over the years has been consistent, just highlighting the cultural importance of these family support workers. And they're ultimately tasked to identify women who would benefit from additional supports in pregnancy to ensure that they're confident and capable parents, particularly in relation to identification around social supports, cultural identity, childhood experiences, financial stress, housing stability, and of course, healthy relationships. And within IUE and this program, we work to the ways and our cultural integrity framework, which is much of the work to improve health inequalities. And we know that sometimes that does lie beyond the health sector. So through the creation and review of social and emotional wellbeing plans, our mums and our family support workers can address any identified barriers that may be in the way of mum accessing healthcare. The family support worker will ultimately provide guidance and promote a use of holistic strength-based approach that acknowledges the broader social and emotional influences that on health and our family's well-being. The family support worker we'll work with our families to break down those social determinants, ultimately to raise a strong, black, deadly family. I'll go to the next slide, please. So this is our extended team, and you can see the entrance of our hub. And so the network of support continues, so you don't just get the dedicated midwife and your family support worker, but one of our most valued services, which sometimes can be overlooked, is our transporters. Being able to connect our families to clinicians, whether it's at the hospital or at the hub, or to get our mums to an Aboriginal medical service, makes the world of difference. When a young mum has 2 young babies already and she's 7 months pregnant, and the last thing mum will do is catch public transport and therefore miss her antenatal appointment. So our transporters are beyond drivers. They provide a safe space for our families and our mums to immediately connect and build trust with the program. Our families do disclose varying detail to our transporters, who will then have an understanding of what to do with that information. They're often negotiators, encouraging our families to get into the car and attend the appointment that they perhaps have no energy for. They'll negotiate with families' partners, with mum's partner, about, why it's important to be a part of the journey and not just the birthing moment, and highlighting the significance of, being together in a collective to help raise a strong, black, deadly family. Our drivers, again, are really, I suppose, skilled in helping mum regulate her emotions too once she does get in the car. Perhaps she's had a really difficult morning getting the kids off. Perhaps she's experienced some, some domestic violence within the household, or perhaps the demands of caring for elderly family members. So being able to help her regulate her emotions and get that support is really vital to the needs of the families. So on entering our hub, you'll see there Annie, Denise and Mickey, who is now also pregnant and on the Birthing in Our Community program, are there to wrap your arms around you. They'll find you a cuppa and whip you up a good feed. Our community, and once you've come through the BIOP program, you are still a part of our community, and so donations are constant and are provided to the hub. So Annie, Denise will rally any resources and ensure that mum and bub have what they need. Things like registration and paperwork, support like that is actually handed out to our families, so they understand what to expect. Why do they need a Medicare card? How do they apply for Centrelink? So all of those needs are actually provided for mum while she is in the centre. And like the rite of passage, once bub is born, her pic is proudly displayed on the wall with the other 240 mums for the year of 2020. Extending past that, again, we've got additional resources at the hub, which we refer to as our mental and physical strength. And that's our practice nurse, our social worker and our psychologist, who are dedicated to the program, and our families. So Monique is our practice nurse, and she's tasked to focus on health promotion, understanding the Red Book, the importance of keeping it, immunisation schedules, the options around contraception, and again, adopting an Aboriginal medical service. And we're lucky enough every Friday to have something called a community day, whereby we will provide lunch that the mums help us make while they're learning how to, cook meals on a budget, of course. So we'll sit down with our families and eat with our mums and our babies alongside our psychologist and our social worker. So it's never too overwhelming to have a good yarn with Susan and Claudine, rather than referring or making the recommendation to mum, perhaps you need to see the psychologist. It's as easy as, did you want to have a yarn with Claudine? Remember, you had lunch with her before and you spoke about this. So it makes it a lot easier for mum to be open to that option. And Susan and Claudine make themselves available at the hub or a medical service, in the park or mum's home, wherever mum feels safe. So the Birthing Now community team are here not only to help mum birth baby, but to also empower our families to build a strong, black, deadly family. On the next slide. I'm going to just talk to you about a few of our mums, and they've all given their permission for me to do so. So this is, and we talk about our families, they are the heart of the hub. So this is Tina. She was, this was her 10th pregnancy, little Sebastian that you can see there. Unfortunately, all of her previous children were removed due to drug and alcohol and domestic violence. Tina engaged really early in her pregnancy, and was actively engaging on community days. So she would come in every Friday and all of her antenatal appointments, and you know, it really immersed herself in the opportunity to connect with other family members, with other mums, but also this wraparound services that exist within the birthing in our community. The most important thing is we help to navigate through the interactions of child safety, which is really overwhelming for any mum, especially someone who has lost 9 babies to the system. So she received intensive support from everyone. So not only her midwife, but her family support worker. She built a really great relationship with our social worker and our psychologist, and our transporters as well. So she was, again, like I said, very immersed in the program. She has been clean since early pregnancy and free of DV. So she made these choices and helped herself with her family support worker build a good plan about how she can ensure that she can be the best parent that she can possibly be. And we were then able to help her with finding time and agreeing with child safety about how she can spend more time with her other children who were in care elsewhere. So Tina promotes the service and definitely says, with the support of my family support worker, I wouldn't have come this far in my journey. Having someone who has faith in me made me start to have faith in myself. The next slide. This is Sam. Sam's had 2 babies with the BIOC program. She isn't from Brisbane itself, she's just outside of Brisbane, but so she felt very isolated within this space because of that very reason. Her older son wasn't attending school and had a lot of behavioural issues, so we were able to get her support through the paediatrician and ENT dental care, who was also utilising the space within the hub at Salisbury, and we were able to get Xavier into the Murray School, which was local, and support to help him with his challenges. Psychology support was also put in place, not only for Sam, but for her older son as well. And she made a lot of really strong connections through Circle of Security, which was an 8-week program that we offered at the hub. So Sam states that the hub is her safe space. Use mob like family. You're not stuck up, and I can be myself. So Sam is definitely a part of our family unit and has grown incredibly as a strong mum of 3 young boys that she's raising. The next slide. This is Beck. So Beck has had 3 babies with the BIOC program. She was a family support worker on our program, has since relocated to Sydney, but she grew up not knowing a whole lot about her culture. And her father was Indigenous, but her mum who raised her was non-Indigenous. So she was able to not only come onto the program as a mum, but eventually as a family support worker, and it really deepened her connection with culture and community. So understanding the importance of engaging and connection, and also being aware of the isolation away from culture and what that actually means. And allowing her to take that cultural journey at her own pace, in her own means, was really powerful. So she states that, you know, she feels very proud of her Aboriginality, that she can now support her own children through that process of learning, although she didn't have that opportunity while being raised by her mum. She states that my midwife and the whole team made me believe that I can do anything. So that's Beck. Go to the next slide.
So I'm going to explain a little bit about how we did it, and we've developed what we call the RISE framework. So the RISE framework stands for redesigning the health system, investing in the workforce, strengthening families, and embedding community. And we've got, I think you can see that Christy's already explained quite a bit about how the RISE framework comes into action, but we'll show you, we've got a few slides that explain a bit more. And under each one of these RISE, each one of these sort of thematic areas, there's quite a lot of evidence base to the intervention, the complex intervention, which we'll show in the next slides. But the most important thing about this program is that it's actually, it's all about Aboriginal ways of doing, being, seeing and knowing, and it's underpinned by the importance of Aboriginal connection to country, Aboriginal dreaming and law, and mothers and babies and families at the very centre, but also the importance of ceremony. So that's the underpinning, the most important underpinning part of it. And then we've got the components that we'll just quickly go through now and show you a bit more detail on. So R is for the redesign of the health service, and we've already talked a little bit about that. So the evidence base around that is continuity of midwifery care. There's strong evidence base there. The family support worker also. We think it's the developing relationships and the ability, the way the model works to allow the development of a safe, trusting relationship from very early in pregnancy. That leads to the trusting developing relationship between the mums and the practitioners, and that can often lead to disclosure of things like women might be homeless, they might be couch surfing, they might have a partner in jail. There's all sorts of things that they may not tell, they may not have told in the past, but if they open up to the team at the hub, then the team at the hub can actually do something about it. And that can be so powerful that at the end of the day, mum goes home with the baby that previously may have actually been taken by child safety because of the concerns about the environment that mum's living in. So it's a very holistic service and trying to integrate with other services, not trying to replace other services. For the midwives, it's a different way of working. So yes, midwives are used to working in a continuity of care model, and many midwives like working in this way, but it's not, it's unusual for them to be working side by side with the family support worker. So midwives need to it's a new way of working for them as well. The midwives that we've interviewed over time say that they believe this continuity with a midwife, if continuity of care is the gold standard, which we know it is in midwifery, then birthing in our community is platinum because of all of the different specialties that support the mum. Continuity of midwifery care has been shown in randomised controlled trials to reduce preterm birth by about 24%. So it's a key component of the complex intervention. The midwives say that the family support workers are a godsend and they couldn't do their job without them. They keep me right, and that's sort of certainly culturally right as well. And I find it an honour to work alongside such culturally proud women and support them to become the best versions of themselves. I'm going to hand over to Christy. We'll just go through these 4 slides reasonably quickly, and then, I'll hand over to you, Christy.
Great. Okay, so investing in the workforce, obviously having the Indigenous workforce increase. So we started with just 3 Indigenous staff members and now are at 18. So Indigenous workforce, we've got the program manager, family support worker, team leader, 6 support workers, and you can see the cohort of Indigenous workforce. The non-Indigenous workforce, so we really do focus on supporting them through this process as well, because like Sue did say, this is a new way of working. So ensuring that they understand the cultural integrity framework is really important, and ensuring that we've got clinical and cultural supervision that does provide support and guidance to our non-Indigenous workforce is really important. Yeah. So the next slide. So strengthening capacity within our families, it's all about growing strong, black, deadly families. So the team at the hub deliver different initiatives that are strength-based, focusing on our mum and baby's needs. The hub then offers services to strengthen mum's capacity to be the best mum that she can be. Most of our mums are just wanting social connection and connecting with our culture and finding pride in our identity, which is ultimately the beginning of Bub's belonging. So things like belly casting and art activities is really awakening, and it supports mum through the process of connecting with oneself and our culture. Community days, I mentioned that before, every Friday we do get together and we have an education piece, and then we sit down and have a yarn about what is happening within our community and connecting with our culture, with our elders. We also offer different programs within the hub as well. Circle of Security is our most popular, which is an opportunity to reflect over how we were parented and perhaps consider that perhaps I don't want to parent that way moving forward. So being aware of that, and then putting in support to be able to ensure I can be the mother that I can be, regardless of where I've come from. Keeping families together and changing the representation of our mob and changing the narrative within our community about I'm not good enough. Well, in actual fact, you are. And the beauty about who we are is that it's not just one, it is a collective, and together we will raise our babies. And the crucial role again around family support workers, they're all young, strong Black women as well, some single mums, and they have shared their journey and how they've risen above, and how our families and mums can do it too. So they're role modelling what we ultimately want our mums to achieve. I'll go to the next slide. Voices from our dads. So it's important that while we continue to have a model that is centered around our families and bubs, that our mums and bubs, sorry, that we do talk to our dads as well. And we went through a program whereby we actually sat down and surveyed some of our dads and did some research about what it is that they're looking for. And the voices from our dad, our good father is present, a provider and a protector, and reflects on how to be a better father. One of our dads spoke about, I understand that there was going to be a lot more responsibilities dealing with a child, but I didn't quite understand the pressure of it until Bob was there. The next slide. Dad's voices continue. So to be a good father, men need to support to heal and move on from their past, loss, trauma and mistakes, and manage their stress of fatherhood. I used to blame everything on him. His father he's talking about, like me getting into trouble and me getting locked up. I realized it's not his fault. He was never there. So how can I blame him, So again, talking with our dads and hearing how they're reflecting over parenthood and how it's changing their life as well. And getting this research and this data helps us then work out what can we do to support our families as a unit, rather than just focusing on mum and bub. So the father inclusive practice for the BIOP program. So maternal health services that are welcoming and safe for men. So these are some of the key takeout points from this. Having a maternal health staff who is clinically and culturally competent to engage with support men throughout their partner's pregnancy. For dads groups to facilitate the provision of culture, community and peer support to new and expectant dads, and community health promotion campaigns promoting the strengths and challenges the stereotype of Aboriginal and Torres Strait Islander dads. We recently had a gentleman, I suppose a father within the community, Dion, come into the hub every Friday on community days and just sit amongst our mums when mum was grabbing a cuppa, offer to take baby and just support our mums as any father would. Or uncle, and it was really great and eye-opening for mothers to actually see a dad within the hub, and then went home and spoke to their own husbands about what it is that they need from them to help them be a better mum. So it's just also generating a lot of conversation about including dad in the process of this journey. Next slide. Embedding community ownership, Indigenous governance and control is so important in this space. For me, E represents authenticity and how do we ensure that this program is truly owned by mob. The hub is a home for our families. Our community tells us what they want and we respond to their needs. But thanks to the partnership, we have Indigenous representation at all levels, allowing our mob's voice to be heard. Our elders, our aunts guide us with their wisdom, their life's journey and their birthing stories to ensure that we are lifting our families to be the best they can be. The importance of the hub ensures community engagement, cultural connection with our aunts, community elders, sisters, our storytelling needs to remain and continues through those days. Cultural education, the importance of Sorry Day and celebrating NAIDOC, and giving us a strong sense of cultural identity and sense of belonging. And not only do we rely on our community and our elders to guide us, but also the cultural integrity framework of the ways of seeing, knowing, doing and belonging and being empowers our families to raise strong Black deadly families. Next slide.
So the research team was a pretty large research team. It was had representation from all of the 3 organisations and the university, several universities. We conducted a longitudinal cohort study, and we interviewed mums at 4 different times in pregnancy and postnatal up until their babies turned 6 months. The main thing about it was that it was mixed methods, but it was participatory action research. So we had mechanisms within the research to be able to feed back to the steering committee that oversaw the program, and they were incredibly responsive. So when we did our first 100 surveys, that was when we were kind of blown away with the numbers of people that were homeless, that were couch surfing, that hadn't eaten in the last 2 weeks, and various other social determinants that were really concerning. And that led to a funding bid to Queensland Health, which actually gave us the additional money for the hub and additional family support workers and social services. So that was a crucial part of the study, the participatory action research, and has led to lots of changes and modifications as we've gone along. We've learnt a lot about the design of this program. But part of it, of course, was also the looking at the numbers and the data. And we would look at the numbers and data and provide reports to the steering committee quite regularly. And really early on, it looked like we were getting some really good results. We were seeing increased vaginal birth rates, increased breastfeeding, and it really looked like we were seeing a reduction in preterm birth, which was one of our primary outcomes that we were aiming to change. It wasn't a randomised control trial, so that was always going to be you know, a challenge for us, how we managed selection bias in the study analysis to see whether we really were seeing a drop in preterm birth, or if it was just, you know, the healthy mums and bubs that were coming to this program. So a little bit early on than we had initially planned, the steering committee asked us to look at the preterm birth rates and do some analysis and see if it really was as good as it was looking. So we did do that. We looked at all of the Indigenous babies across 2013 to 2017, and then we looked at the different models of care that they might be coming through. And there are lots and lots of models of care at the Mater Hospital, and we excluded babies that in multiple births, anyone that had gone to the specialist clinics for drug and alcohol, or the specialist, anyone with a fetal anomaly. And we tried to get 2 groups that we could actually compare, those going through standard care and those going through birthing in our community. At this stage, birthing in our community wasn't resourced enough to be able to provide care for all of the Aboriginal and Torres Strait Islander babies. We saw through our analysis that before matching, the standard care women were more likely to have had a previous caesarean section, a previous stillbirth, thyroid disease and essential hypertension. And the birthing in our community women were more likely to be teenagers, single mums, first babies, and to have either renal disease, hematological diseases, gestational diabetes, pregnancy-induced hypertension, and antepartum hemorrhage. So that was pretty challenging. There were 2 different groups. So we decided we needed to use propensity score analysis to balance and match the groups for analysis. And we did manage to see a good balancing after we did this analysis. And the results were incredibly exciting and reassuring. So for us, we found that there was approximately both before and after matching didn't change the results much, about a 50% reduction in the odds of preterm birth for babies in the Birthing in Our Community program. So we have a take-home message, and Christy's going to talk to this. And just before I hand over to her, I think the really exciting thing about what we've done is we've put policy into practice. So there's strong policy drive about what's called birthing on country, and in our instance, it's the Birthing in Our Community program. The components of our program are straight from policy documents and from the evidence base, but we've actually managed to do it and do it on the ground in a multi-agency way. And handing over to Christy for the last slide.
Yeah, so I suppose the most important thing has been leadership at all levels, with our partners needing to contribute resources and expertise, and taking a strength-based approach and being solution-focused. Leadership from the very top has been integral to the solid foundations of the service, and ensuring our mob are leading in the redesign, that mob have control and access to our data, and empowers the community to own the design and create a pathway that we know is best for our families. The model of care around mother and child is centred and is always evidence-based. Reframing the research, Indigenous research leadership, and meaningful measures and methodologies. Determinants of wellness, so promoting individual and community agency, and of course the RISE model. And utilising the RISE model as a manager has been critical and a radical change, but also provides me a very clear method in prioritising what it is we need to do. And the investment is, a return on that investment is around social justice, health, a better start to life, and building capacity within our community as well. So thank you.
Thank you, everyone. We'll hand over now back to Sarah.
Great, thank you both.
I presume.
Yeah, thanks, Sue and Christy. That was super interesting presentation. We'll now take questions through the chat. So we just had a couple of comments as you were talking along, just I guess remarking on how impressive that reduction was in your preterm births. And really, I mean, it's hard to think of another program that would have seen an effect size of that nature on preterm birth previously. So that was something that was commented on. And also, I guess, just how holistic your services were was impressive to our audience. And it seems like, obviously, with complex problems like this, you do need to go in with a holistic approach, but your program seemed genuinely committed to really addressing a range of social determinants that could have been contributing to those preterm birth rates. I guess one question I had, and please chip in others if you've got questions, is because the program was so holistic in terms of the way that you held those women's hand through that process of pregnancy, birth and child rearing, I guess, what other outcomes did you observe? Because it seems that you would have improved so many things other than the preterm birth rate as well. Do you have any sense of how your program is improving other types of outcomes?
Yeah, we do. So it's a big sort of 5-year study, and we've only just cleaning the data and getting onto the proper full analysis now. We've got an economic analysis that is looking at the cost to both families and to health services. But with the analysis from early days, all of those outcomes that look like they were improving continue to look like they were improving throughout. So, I mean, we're going to use propensity score for a lot of the analysis probably because the groups aren't well balanced. But things like normal vaginal birth rates, breastfeeding rates, reduced intervention in childbirth, all of those sort of things that you also see with to some degree with midwifery continuity of care models we've seen here. But some of the things that we're seeing, and some of it's small numbers, and we're still looking at qualitative data because we've done a lot of focus groups as well, are the things like the stories that Tina told at the beginning. So the difference to mothers going home with their babies after birth rather than having the babies taken from them and going out to foster care. Christy, you can probably talk to that, but that's just mind-blowing, really.
Oh, totally, yeah.
Yeah, I would say that looking at the Birthing in Our Community program on the south side and then similar programs that we've got on the north side of Brisbane, what we have seen is that the very few referrals are actually made outside of the Birthing in Our Community program as well at Salisbury, where we've been able to really engage deeply with the families to understand what those barriers are. And sometimes it is as simple as housing, but there's far more underlying issues, whether it is, the way in which a woman was parented and therefore helping her reposition or reconsider her way of parenting. And challenging that and giving her that education changes everything for that family and allows them to keep out of the family wellbeing system, I suppose, where in a different space, we're seeing those, if we're not catching them early, we're seeing them in, you know, being cared for in different ways because they are, you know, there is heavy DV happening, or, you know, children are starting to become unwell or playing up and stuff like that. So we do have less referrals coming out of the BIOP program because it is being managed so well with the wraparound services. So that's a massive thing that we did, you know, one of the great results we're seeing from the program. And again, with child safety, you know, unfortunately there are at times needs, it does need to happen, but it's about making sure that we have well-informed families who, you know, can really advocate for themselves and be the best parent they can absolutely be, rather than getting caught up in the system purely because perhaps they were a child of the system as well. So we're seeing a lot of positive outcomes from that, working as a collective.
Excellent, thank you. And Suzanne has just commented too that it's just an exciting time in health to acknowledge the importance of understanding and incorporating those social determinants of health into care plans. And I guess that there's really a lot for everyone to learn, even well beyond your program, about seeing the way in which social determinants are being incorporated into the plans in your program. We did have a question here about, I guess, just Suzanne as well, wanting to understand a little bit more about how your model of care worked in partnership with the ACCHOs.
The ACCHOs, the Aboriginal Community Health Organisations. Christy has driven a large integration agenda. So Christy, why don't you talk about that? I mean, that's been an amazing part of the whole program, really.
Yeah, so I suppose it's been about making sure that we've got the right governance that's sitting in the right space. So having the buy-in from our senior leadership team and then cross-referencing that across the three stakeholders or three partners has been really important. And then ensuring that we're communicating at all different levels has been, I suppose, successful in maintaining the relationships and the not interest, but the understanding of what we're trying to achieve. So that's really helped us establish that and work across the businesses.
I think the other thing that I've noticed, sort of having worked in this space for a very long time, is that there's nearly always been problems, any service I've ever worked in midwifery, that integration with when women are being discharged and going back to their community, and whether they're being discharged in Darwin and going back to remote communities, or whether they're at the Mater Hospital and going back to their GP, there's always been problems with, you know, discharge summaries going missing, discharge summaries not having the right information on them, women falling through cracks if they're women that are, you know, have got some significant needs that need to be followed up. What this program has also done is been really proactive about that. So working out where women are being referred to, and often that might be a phone call rather than just sending the discharge summary. But also if they don't have a local AMS or an Aboriginal Medical Service, or they don't have a local GP, helping them find one and helping them understand the importance of one. And we're lucky here in Southeast Queensland because through the Institute for Urban Indigenous Health and their member bodies, there's 22, is it now, Christy, 22 clinics across the region?
Yes, and can I just add to that too, Sue, is that we do find that a lot of our families that do come onto the program, or young mums especially, just pop into a mainstream medical centre to get a pregnancy test. And so it's really important for us to focus on that cohort of mums to be able to ensure that we're talking about adopting a Aboriginal medical service very early on in the piece, because they are young, fit, healthy women, but they don't understand the importance of what is to come. But again, we talk about, you know, birthing is a moment. We really want to ensure that our families build trust and acknowledge of the health system can, you know, one, keep their babies, you know, healthy and continue with their health journey. So we do have quite a intensive program where we've got our practice nurses involved with family support workers, and at scheduled times throughout pregnancy and postnatal, we are talking about the adoption and taking them out to medical services and understanding that, you know, what does immunizations mean and what does that look like? So, you know, being able to introduce them to another family support worker that is at a local AMS really helps them establish that relationship and build that trust. But it's very important that we don't feel like our job is done until we know very well that the family have adopted or had the choice to be able to adopt an Aboriginal medical service.
Great, thank you. There's a couple of questions come through now that are sort of kind of, I guess one question's about, I guess when we do a program in the context of research and evaluating it at the same time, we're often putting a lot more resource into the intervention and what we're doing because we're also evaluating it. But I guess help us to understand how do you think that it seemed like the program existed prior to the evaluation. So in a sense, you're building on something that was already sitting there. So I guess what the question is really helping us to understand the ability to implement something like this outside of the context of research as something that could be sustainable and be part of usual care instead of being part of a research project, I guess. Does that make sense?
Yeah, look, that's a fantastic question because, of course, we've seen these results here in this one setting. Can you roll it out? Will you get the same results in other settings? How easy was it? How hard was it? Were the players on the day critical to it, or how much did the research contribute? So, and that's where our research wants to go next, of course. We'd like to see widespread implementation, but we think that the RISE framework is something that's really going to help other services. It is complex. We think the RISE framework could potentially be adapted to research in juvenile justice or education or anywhere really. But for us, it made it very clear the parts of the intervention that we think are critical. So we've got currently, there's a realist review underway at the moment to try and double check, you know, what parts of this complex intervention do people think were absolutely critical and what was nice but you could probably do without. And so that will help us know that. And also with the preterm birth, we'll be looking at the data more carefully and looking at the predictors of preterm birth and seeing, you know, when you talked about the effect modifiers, which ones were more important and which ones were really probably driving some of this. So we're going to try and look at the data to tell us that. We've got applications in, of course, for further research where we'd like to actually see if we can replicate the service. We're already working with another service, Waminda, in southern New South Wales, which is an Aboriginal medical service down there, and they're also wanting to develop their own birthing on country service with using the RISE framework. You know, it's a regional area, it's not an urban area. How well can you, how easy is it to do that and set it up? And it's always got to be locally driven and, you know, take the local context into account. So we've got research that's doing that, and we're trying to, or hoping in the future to develop tools and things that can help. The learnings, so people like Christy, what she knows and understands, particularly having had several different roles in the organisation and the steering committee that oversee it, are, you know, have got extraordinary knowledge. So how do we get that knowledge out to more people so that they can do it in more places? And that's what we're grappling with at the moment.
So it's great to hear that you're planning that stream of research as well, which would be great. And I guess in a similar vein, like Fiona Kiora from across in New Zealand, she has wanted to know, I guess, was there anything that you thought that you would want to use, like if you had the option for more funding or to add more services or resources to the program to support families, was there anything on your wish list, I guess, that you would like to see added into this model that if you had extra resources you'd like to add in?
You're already doing that, aren't you, Christy? With so some of that, we've had a lot of sub studies as we've gone along, and one of them was the sub study with the dads, and some of the areas that became areas of important focus were around the child safety, around the care in the neonatal nursery, around what happens after 6 weeks. When the family's, mum turns 6 weeks, and that's when the midwifery care stops, but what happens to the family then? So I think, Christy, you're already doing
We are. So we've just started to expand our service from when mum does get discharged, I suppose, from the midwifery team, that she gets the option to stay connected with the family support workers, and we look at early education. So it's somewhat of a play group where we're starting to bring our families together, and it is at a different site. Good thing or bad thing, we're yet to explore that. But they will again be meeting on a regular basis and continuing to have those education pieces, and also looking at the milestone of our babies and how they're growing and when to ask questions and what to be suspect of, etc. So and utilising that time as well to ensure that mum has adopted an AMS and is engaging with that service, and looking at what other babies they have, so whether it is toddlers, etc., and how they can help them support mum getting into something like a deadly kindies, so it is becoming more than just about the physical health. It's also about the social and emotional well-being of that family unit, and the education of mum knowing the childhood development milestones.
Yeah, that sounds like a wonderful opportunity to kind of capitalise on the relationships that you've built throughout the program to keep supporting the women into that next phase is wonderful. We've just had so much positive feedback on the comments just about how amazing it is, and congratulations on your impressive study, and thanks for sharing. And so lots of good positive feedback from the audience today. Also just wanting to know, I guess, how are you going with capacity in terms of, do you have waiting lists, or can you accommodate all the women that are coming and wanting to be part of your service? And how's that going?
Over to you, Christy, for that one.
Yeah, sure. So right now we are able to support all of the mums carrying an Indigenous baby birthing at the Mater Hospital. We can do that. We are seeing other little biocs pop up around Southeast Queensland, so we will be able to rely on those and lean on those if we do get too big within the Mater system, I suppose. But right now we have one family support worker per 2 midwives or thereabouts. So it would be ideal to be able to increase the cohort of family support workers so we can take a more intense approach with each of our families. So having one family support worker per midwife would be ideal.
Yeah. We've also had this is starting to get more my alley here, the health economics, but like a couple of comments come through about just, I guess, how do you take what you found in your research and really convince, the comment from Natasha here, convince jurisdictional health departments to implement the evidence? And, saying that, I guess, what you've known about continuity of care in midwifery for decades, you've still struggled to get the system to fully respond to that evidence. And how can we convince health services that the investment in this sort of service redesign and community engagement is going to pay back? And I guess someone else has said as well, how do we demonstrate that economic value? And I know you've got that planned, but I guess do you have any insights, I guess, into how you can take your learnings to really convince health departments about the value of this sort of a service?
It's so hard, isn't it? So we've taken national policy and put it into practice. We contribute to many national and state roundtables and policy development. We know that Queensland policy has just, a new policy came out last year, and it's got our research quoted in it. It's reflective of what we've found, so that's fantastic. But how do you actually see it on the ground? We're lobbying, working with ACHOs in other areas that want to set this up, and we've got funding bids in all over the place. But even trying just to get governments to agree to release some of that midwifery money to the Aboriginal community controlled health organisations is really difficult. So we've got a lot of evidence. We're going to continue to get more evidence. We're getting more savvy about how to communicate that evidence. We've been interviewed by Norman Swan, which was great, but it takes so much to try and turn around a system, a health service that has been the same way for many years. So we keep going, but it's a hard slog. The economics of it. So for every preterm baby, that's sometimes, it's thousands and thousands, 60,000, 80,000, maybe, more than 100,000 just for that first episode of care. That's not even counting all the longer term health costs. So the economic argument, I'm sure, is going to be fairly solid, particularly if you look at the social determinants of health of employing so many and providing educational avenues for so many Aboriginal and Torres Strait Islander women in the service. I'm sure it's going to be solid.
I think your economic arguments, as you put that evidence together, are going to be incredibly strong. I mean, from work we did in child protection, anything that worked in child protection was highly cost effective. So the cost offsets are so large in the types of outcomes that you're preventing for these families and children that I think it will pay off in spades. It's just getting it down, isn't it, to have the argument on paper, and all the evidence helps, though, doesn't it, over time to build the case. But yeah, I think you're out there in the coalface and seeing what a lot of researchers experience in terms of the difficulty of translating their research right through into policy. But we appreciate your efforts.
Yeah, putting the data and the evidence in the hands of the Aboriginal services is probably the best thing that we can do as researchers, because having that evidence and having their data fed back to them as much and seeing the change, that makes them much more powerful to be able to actually speak to what their own services can do in this space. So I think that's a crucial part of it.
We've had Fiona comment that, interestingly, that some of the research coming out of psychology of change is talking about kind of change being sort of emotional rather than intellectual, and that's interesting to reflect on too. And I guess, Sarah, we've had comment here, is there anything that you feel that others you've got a lot of people on the line here that are in your research community, is there anything that others within your community could do to help with translation of this work?
Wow, that's I think we've gone over time, and that's a big question. So I think that's a very tricky question. We all know how hard it is, don't we? So, you spend years doing massive big grants, you don't even get them up, you're lucky, I think it needs research support for translation. This wasn't easy. So I don't think we can expect that Aboriginal medical services and tertiary hospitals around the country are just going to pop up and say, oh yeah, we can do that. It's hard work on the ground doing it. So I think the implementation science, so working with other researchers that have those skills, the implementation science, the health services research, the health economics. So, we've got a certain amount, but it's the greater research community that could really help us do this scale in a way that would be so exciting.
Okay, so we encourage those on the line to reach out to you. They can contact you through email and that follow up on any things they'd like to follow up offline. But we'd really like to thank both Christy and Sue for such a wonderful presentation and sharing this research with us. We've had such good response to your work. So keep up the good work, and thanks so much for taking your busy time out of your schedules to share this with us today.
Can I just also acknowledge Christy, because as we all know, COVID-19, she's been so busy. I thought that she may not have been able to make this presentation, but she said it was important and made time. So thank you, Christy. I know you've got a massive clinical area out there you're responsible for, and you've been absolutely smashed with busyness. So we really appreciate it.
Yeah, thank you very much, Christy.
Thank you to all three of you. And just a reminder, we'll have this online in a day or so. So if there's people that missed it, if you just let them know, they can access it on our website.
Yeah, so those online can share it with their networks as well. That would be wonderful.
Brilliant.
Thank you, everyone. Thanks, Sarah, for organising it for us as well.
Yeah, and any suggestions people have got as well, there'll be an email comes around, so you can just respond to that with my email. If you've got any suggestions for other topics or speakers, please let us know. Yeah. Thank you.
No worries. Thank you, and thanks to our participants for their engagement too. Thanks, Sue and Christy. Bye.
Bye.